I am presenting the first case of student clinical meet, a case series of unusual bleeding disorder. Case X, 71-year-old female, resident of Una, Himachal Pradesh, presented with the swelling and easy visibility of the right bilateral upper limb for 3 months, exacerbated in August first week, and pain with passive movement of the finger for 7 days and lower abdomen pain for the 4 days. And background history, on July last week, she had a swelling over the dorsum of the hand, which she underwent the drainage followed by the uncontrolled bleeding. She was referred to the DMC Ludhiana, where she underwent the panel of test. She has detected to have a deranged EPTT with a low factor rate. She referred back to the PGI. The easy visibility and the swelling were insidious in onset and gradually progressive, of no spontaneous in onset and no prior history or no family history of bleeding disorder. The swelling is associated with the pain while passive movement of the fingers. The pain abdomen, which is the right lower quadrant, insidious in onset and gradually progressive. On general physical examination, she has a severe pallor. On pulse examination, she has an absent radial and ulnar pulsation in the right hand. The rest vitals were normal. On head-to-toe examination, she has a hematoma of 5 cross 5 centimeter on the bilateral below the medial epicondyle of the elbow, with AIIMS on the bilateral arm, forearm, and the right iliac fossa, with a bluish discoloration of the finger and of the right hand, and horizontal nick over the dorsum of the hand. On systemic examination, per abdomen, she has a tenderness with a swelling of 5 cross 6 centimeter with no organomegaly. The second case, case Y, 82-year-old male, resident of Gulmarg, Punjab. He presented with a bilateral lower limb swelling with a bluish discoloration skin for 2 days. With the background history of type 2 diabetes, hypertension, and cardiac disease post CABG, he has similar complaints of over the left arm, which self-resolved. And the swelling was insidious and also gradually progressive. There is no prior history of bleeding, no history of family history of bleeding disorder, or no history of drug intake. On general physical examination, he also has a severe pallor with a blood pressure being a 150/60. On head-to-toe examination, there is a bluish red discoloration over the medial and lateral aspect of thigh with a right lower limb swelling of a pitting type. On systemic examination, he has a systemic examination within normal limit, and local examination shows the palpable swelling on the medial and lateral aspect of the thigh. The third case is a case that 71-year-old male, resident of the Ambala, presented with the passage of clots in the urine intermittent since the August 22, with a recurrent bruises over the trunk and extremities since September 2022. Now present with the swelling over the right scapular area. For the intermittent hematuria, he consulted the urologist, underwent the cystoscopic removal of the clots, and started on tamsulosin. The recurrent bruises and ecchymosis were spontaneous in onset and resolved spontaneously. In known case of type 2 diabetes mellitus, hypertension, and acrofacial vitiligo, the swelling over the back was insidious in onset and gradually progressive, no non-traumatic, no prior history of bleeding or no family history of bleeding disorder, no history of drug intake. On general physical examination, he has a severe pallor. With a head-to-toe examination, he has a hematoma over the 10 centimeter largest diameter with a hyperpigmented patches which were irregular in border with, over the acral and lip and tip areas. On systemic examination, which was normal, local examination shows the swelling of largest diameter being 12 centimeter, the local rise of temperature, and the large bruise over the back. The clinical database, all the 3 index cases were elderly at presentation. The site of bleed being the skin, soft tissue, and the mucosal bleed. The severity of bleed, the case X has an artery compromise, case Y has a venous compromise, and the case Z has a hematoma of more than 12 centimeter. The associated conditions being Y has a type 2 diabetes, hypertension, coronary disease, and case Z has a lip tip vitiligo, hypertension, and type 2 diabetes mellitus. And lab values of the case X shows the severe anemia with deranged LFT with isolated APTT prolongation. On further investigation, the viral markers, the paraperitoneum workup, the autoimmune workup, and the tumor markers being negative. On imaging investigation shows the USG Doppler, the absent at the presentation shows the absent flow noted in the distal artery and arteries of the radial ulnar artery of the right forearm. And repeat scan on the 12th shows the biphasic flow. And CCT chest and abdomen shows the mild hepatomegaly. The lab values of the case Y shows the severe anemia with the isolated APTT prolongation. On further investigation, the viral markers, autoimmune workup, and paraproteinemia workup, and the tumor markers being negative. The venous and arterial Doppler of the lower limb shows a partial thrombus in the right femoral and popliteal ligament with a hematoma. On subsequent scan, there is no evidence of the thrombosis. The US whole abdomen shows the grade 1 prostatomegaly, and CCT chest abdomen shows the hepatomegaly with a prostatic enlargement. And lab values of the case Z has a severe anemia with the isolated APTT prolongation. And further evaluation, the viral markers autoimmune workup, the paraproteinemia and the tumor markers being negative. The USG of the leukocyte shows the maximum diameter of the 15 centimeter over the right scapula and the lower back. USG abdomen or the normal limit, and the PET shows there is a hematoma over the posterior chest wall. Based on the investigation, we have isolated APT prolongation with the platelets within normal limit and the anemia of severe. We have causes for the APT prolongation. We have inherited and acquired. Inherited, we are not thinking because of the age at presentation, site of bleeding, and no prior history of the bleeding or no family history of the bleeding disorder. The acquired causes, we ruled out the drug intake in the history. We left out with the acquired inhibitor factor against the factor 8, 9, 11, and the 12. Acquired von Willebrand disease and the lupus anticoagulant. For the further to find out the cause of the deranged APTT by the mixing studies, we found out to be mixing study there is low titer of factor 8 with high titers of inhibitor level in the blood, which are time and temperature dependent. The factor 8 level inhibitor. Factor 8 and inhibitor level of the K6 being 0.5 and the 45.6 Besserer unit, case Y being 1.4% and the 52%. 52.4 Besserer unit, and the case Z has being 4.4 and the 92.4 Besserer unit respectively. The treatment received by all the three cases being case X received the Visolon and cyclophosphamide along with the FIBA with the transfusion support. Case Y received the Visolon and the transfusion support, and case Z received the Visolon and cyclophosphamide with the IVIG and transfusion support. The unit final diagnosis being the acquired hemophilia A. The point of discussion being the approach to isolated APTT prolongation, the acquired hemophilia and its management. The index cases has an APTT prolongation. If a prolonged APTT, the further to exclude the drug intake like anticoagulants, if the institute has a factor 8 assay activity available, then go with the measurement. If less than 50%, measure the factor 8 levels and the volume demand, the ristocin cofactor and volume demand antigen. If the antibody against the factor 8 is more than 6.6 Besserer unit with a normal volume demand ristocin cofactor and volume antigen, measure the inhibitor titers of the factor 8. If factor is more than 50%, measure the factor 9, 11 and the lupus anticoagulant. If lupus anticoagulant goes to the APLA, if the levels of the factor 9 and 11 were low, then measure the inhibitor titers for the factor 9 and 11 by the Besserer assay. If institute doesn't have a factor 8 assay available, then go with the APTT mixing studies with the 2-hour incubation at the 37 degrees Celsius. If fails to correct to the normal range of the APTT, then suspect an inhibitor, measure the factor 8 inhibitor levels. If correct to the normal range, suspect a deficiency and measure the levels of the factor 8, 9 and 11. Now I call upon Dr. Nitya for the further briefing about the Besserer assay.
Very good morning, everyone. So I will be discussing the laboratory workup. How do we work up this acquired hemophilia patients? So to put it in a nutshell, all of these patients at the time of diagnosis and at the time of follow-up had prolonged APTT, and inhibitor screen turned out to be positive for inhibitor. So the further inhibitor assay was done, and which showed elevated inhibitors in all these patients. So we can see that as the inhibitor titer increases, the factor 8 quantification decreases simultaneously. So a retrospective study was conducted 15 years back in our department. 8 cases were categorized as acquired hemophilia A, and we can see here these patients they had time-dependent inhibitor. However, 2 of these patients are said to have immediate acting inhibitor. As a dictum, factor 8 inhibitors are said to be time dependent, but some cases it can turn out to be immediate acting, which I will be explaining later. So we know that it's an autoimmune disorder with high morbidity and mortality, and the causes being 50% idiopathic and the remaining 50% will be occupied by the other autoimmune disorders, solid tumors, vaccination, skin disorders, and it goes on. So let's take a real-time scenario. When a patient approaches a laboratory or a clinician with easy bruisability and other bleeding history, so the first thing to be done here is coagulation screen, which is comprising of PT, APTT, fibrinogen, and the platelet count. So we have done this, and the patient is now showing only the APTT prolongation. So what we have to do further here? Now we have to know whether there is an inhibitor or the factor is deficient. We know that APTT will reduce the, APTT is an indicator of intrinsic pathway of coagulation. So we mainly concentrate on factor 8 and factor 9 here. So now we have to take 2 plasma, that is the normal pooled plasma here. So this is basically prepared in our laboratory from 20 patients, and the plasma has been separated and stored in aliquots, which will be used for 1 year of duration. And similarly, we have to take the patient plasma. So we want to know whether there is inhibitor or deficiency, right? Now we mix these two things and then measure the APTT. So we perform APTT of all the 3 tubes. If the APTT of the mixed tube, that is the tube 3, if it is said to be prolonged, which means the factor 8, which is present in the normal pool plasma, is not able to compensate the deficiency of the patient plasma. So which means there is a presence of factor deficiency. If the if the patient normal pool plasma is cannot able to neutralize the patient plasma, there is something else which is even still prolonging the APTT. In such case, it's suggestive of inhibitor. So that we further proceed with the inhibitor screen. So in inhibitor screen, we know that there are 2 types of inhibitors. One is the immediate acting and other one is the time dependent inhibitor. So to know that, as the name indicates, it's time dependent, we are going to compare whether it's going to act immediately or in a time basis manner. So we mix these 2 plasma again and then incubate at 37 degrees Celsius to know whether it is time dependent acting. And similarly, a stat tube has been made, that is immediately we will measure the APTT and will know whether it is prolonged or normal. Then measure the APTT of all the 4 test tubes. So here we can see in an immediately acting inhibitor, the APTT is prolonged at both the time. So inhibitor which has acted in its at its start moment will be inhibited at the 2 hourly also. So it will be prolonged at both the times. Whereas in a time dependent inhibitor, after incubation only, we will know that there is a presence of inhibitor. So the examples of immediate acting inhibitors are lupus anticoagulant and factor 9 inhibitors, and time dependent inhibitors are factor 8 inhibitors. So as I said previously, here, even though the factor 8 inhibitors are categorized under time-dependent inhibitor, at its stronger concentration, it even can act as an immediately acting inhibitor. So we now know whether there is a presence or absence of any inhibitor. Now we have to quantify how much the inhibitor is present in that plasma. So for that, we have to do Bethesda assay, which is also called as inhibitor assay. So, for example, if we want to measure the quantity of factor 8, we should, quantity of the inhibitor, we should know the amount of factor 8 in the sample and the amount and the duration, because we know that there are 2 things, which is one is immediate acting and one is time dependent inhibitor. So we have to standardize those 2 things to measure the quantity of the inhibitor. So first take bufferin 10 aliquots, and then now we have taken the bufferin 10 aliquots. Now the next thing is we have to deactivate the factor 8 present in the patient plasma, which is heat inactivated at 56 degrees Celsius, and then the sample is being centrifuged. Then the serial dilutions of patient plasma is made taken, because we want to know at which concentration of this inhibitor the factor 8 activity is reduced. So from one tube, the multiple serial dilutions are made simultaneously until it reaches the tube 10 with the dilution of 1:1024. So in all these test tube, we have to standardize the amount of factor 8. So for that, we have used normal pooled plasma, which is a source of factor 8. So now we have standardized the factor 8 levels and the duration in all these aliquots. And then the tube 11 has been made, which doesn't have the patient plasma. So which means this tube is going to have only the full factor 8 and the buffer. So there is no inhibitor in this. So here the factor 8 activity will be 100%. As the dilution increases, the factor 8 activity will be reduced simultaneously if there is a presence of inhibitor. And we know it is a time-dependent inhibitor, so we are incubating at 37 degrees Celsius, and the patient's
faster.
Yes. And the results are measured in Bethesda units. So we can see here when there is a APTT prolonged, inhibitor screen is performed. And if it is a time-dependent inhibitor, we think about doing factor 8 assay and Bethesda assay. And if it is an immediate acting inhibitor, we have to perform lupus anticoagulant testing with factor 8 and 9 assay and multiple dilutions. And then a diagnosis of acquired hemophilia A has been made. Thank you.
Thank you, ma'am. Further point of discussion is being in acquired hemophilia and its management. An introduction: acquired hemophilia is an autoantibodies related inhibitors against the functional epitopes of the factor 8 affecting the men and women of all the age group. There is 2 peak of incidence in the more than age of 60 years and the pregnancy. The incidence being 1.34 to 1.4 cases per million and characterized by spontaneous hemorrhage in or a bleeding induced by surgery in prior or no family history of bleeding disorder. It can be idiopathic associated with the underlying malignancy or autoimmune disorder. The Journal of Thrombosis and the Hematology. Etiology being the idiopathic, malignancy, solid tumors in the hematology, pregnancy, and autoimmune disorders, and the allergic drug reactions with the dermatological causes. The pathophysiology being a factor 8 acts as a cofactor for a factor 9 to activate the factor 10 to 10A. It synthesizes as a proteolytic process, combines with the volume-dependent factor to form a heterodimer of heavy chain and the light chain. The most of the antibodies are formed against the A2, A3, and the C2 fragments of the factor 8. The against the C2 and the antibody against C2 is disrupt the binding of factor 8 to the volume-dependent factor and the phospholipid. The antibody against the A2 and C3 interfere with the factor 8 with the factor 9 and 10. It's a non-complement fixing and non-precipitating immunoglobulins of the IgG family, which is time and temperature dependent. Follows the second order kinetics. Second order kinetics as type 2 inhibitor is a type in which there is a rapid neutralization phase followed by the equilibrium, which shows there is a functional activity of the factor 8 which gives a protection against the bleeding. And the clinical features being the purpurine soft tissue bleeding occurs in more than 80%, with severe muscle bleeding being more than 40%, GI bleeding more than 20%. Intra-articular bleed is less common.
Go faster.
It's more of an acquired hemophilia. The whom to suspect the recent and unexpected bleeding in a patient who is elderly, peripartum or a postpartum with no prior or a family history of the bleeding disorder with isolated appetite prolongation and mixing study consisting of an inhibitor or the negative lupus anticoagulant antibody. On investigation, first line investigation platelet, it will be normal. The coagulation profile shows isolated appetite prolongation with the lupus anticoagulant being a normal. On second line investigation to find out the cause, like autoimmune, malignancy and infective workup. Treatment being a control and prevention of the bleeding, eradication of the inhibitors and treatment of the underlying disorder. The control and prevention of the bleeding is being the replacement of the therapy by the recombinant protein factor 8. The considered as a first line in a life-threatening or limb-threatening bleeding. The disadvantage being the patient in whom the antibodies present in against the recombinant protein factor 8 level we cannot be used. The advantage being it can be monitored in one stage factor 8 assay. The dose being a 50 to 100 units per kg initially every 2/3 early, the measure the factor 8 level. Second line will be the bypassing agents. We have FIBA and the Nova 7. Both can be given in a non-life threatening and the limb threatening bleeding. It can be used in the antibodies against the proxine factor 8 level, recombinant protein factor 8 level antibodies also. The disadvantage being there is no laboratory to monitor the underdosing or the overdosing of the drug. The other hemostatic being the desmopressin, which can be used in a low titer inhibitor less than 2 Bessera unit and the factor 8 level being more than 5. The tranexamic acid can be combined with the bypassing agents to stabilize the clots. An immunoabsorption technique in which the replacement of factor 8 with the immunosuppression, rapid and safe control of the acute bleeding. Response to therapy can be monitored by the clinically and HP being stabilizers, imaging studies. And the APTT will normalize once the replacement of factor 8 more than 30 to 50%. It is not a good surrogate marker to get the treatment, but not predictor of the therapeutic level of the factor 8. The inhibitor eradication should be given to all the acquired hemophilia patients. The optimal strategy being the time to remission is shorter in the cyclophosphamide and corticosteroid therapy, but there is no long-term survival benefits. The first line therapy being a corticosteroids combined with the cyclophosphamide or combined with the rituximab. The corticosteroid can be given in a patient whom we have a factor 8 level being more than 1 or the Bethesda, the inhibitor less than 20 Bethesda unit. The corticosteroids and cyclophosphamide being the higher CR, the remission rate with the early remission. The second line therapy being indicated in patient who failed to decline in the inhibitor level and failed to raise the baseline factor 8 level after 3 to 5 weeks of the first line therapy. We have a calcineurin inhibitor, mycophenolate mefetil.
Please conclude.
A role of IVIG to immunosuppression agent is the first line. As such, there is no benefit. If patient present with hemophilia with the active bleeding, measure the inhibitor titers. If less than 5 Bethesda unit, go with the factor 8 concentrate. If more than 5 Western bypassing agent Prosign, factor 8 are the emphysema, followed by this immunosuppression therapy. The patient monitoring by the hemoglobin stabilizes.
Skip.
Current status of the patient. Patient X demised on 31st of August due to septic shock because of the source of sepsis being the necrotizing fasciitis of the right hand. Case Y doing well, no new episodes of bleeding. Currently on tapering voicelon 5 mg per day. With the APTT of 31 second. Case Z being doing well, no new episodes of bleeding on off immunosuppression, and APTT being 31 second, no. Take home points, acquired hemophilia is an uncommon disease. The higher index of suspicion in elderly and postpartum with the intramuscular skin soft tissue or a mucosal bleeding with isolated APTT prolongation. Bypassing agents are required for the control of the life-threatening bleeding. The cornerstone of therapy is being inhibit eradication. Further reading.
Thank you, Dr. Sharang.
Thank you.
Good morning, everyone. I'm going to present the second case of student clinical meet today. My patient is Mr. SN, 57-year-old male, hailing from Firozpur, Punjab. He is self-employed, work in IT sector. Patient was admitted under hepatology. Date of admission was 16th of July and discharged on 3rd of August. The patient presented with the chief complaint of fever for 2 months. Background history: in 2017, patient was diagnosed to have carcinoma tongue, underwent resection. On evaluation, patient was found to have cirrhosis, etiology likely being metabolic dysfunction associated steatoid liver disease, which previously known as NAFLD. In 2019, patient started developing shortness of breath, which was incidence onset gradually progressive, MMRC grade 2. On evaluation, patient was also found to have grade 2 clubbing. The Rumia saturation was 89 to 92%. Bowel contrast 2D echo was done, which was suggestive of hepatopulmonary syndrome. In 2023 onwards, patient started requiring low flow oxygen therapy at home and was planned for liver transplantation. In history of presenting illness, patient presented with high-grade fever, which was maximum documented up to 104 degree Fahrenheit, associated with chills and raga, night sweat, and easy fatigability, relieved with the antibiotic. There was a history of diurnal variation of temperature, which was more in night as compared to day. There was no history of any localizing symptoms. In past history, there was a history of patient is a known case of hypertension since 1996. Patient had one intracranial aneurysmal bleed in 2010 and underwent aneurysm clipping for the same. History of carcinoma tongue in 2017, underwent resection for the same. In personal history, there was a history of significant loss of weight and appetite over past 1 month. And family history, there was a history of type 2 diabetes mellitus in mother. There were no other relevant family history. In general physical examination, patient was conscious oriented to time-place person. His BP was 130/70. Patient was having tachycardia. Pulse rate was 108 with regular rhythm and normal volume. Rumia saturation was 90%. Patient had grade 3 clubbing with bilateral pituitary edema. There was no pallor, cyanosis, lymphadenopathy or jaundice. JBP was not raised. On systemic examination was within the normal limits. At the time of admission, during the course of admission, patient had raised bilirubin maximum documented up to 2.30 with conjugate fraction of 2.12, and patient had also developed coagulopathy, INR reaching up to maximum of 1.74. Both bilirubin and INR was on in decreasing trend during the later course of stay in the hospital. Investigations: the viral marker were within the normal limits. Lambda workup was negative. Tumor marks were within the normal range. Ultrasound abdomen was suggestive of CLD with portal hypertension and granulocytis. TPCT was suggestive of, for the same. There was no hypervascular region to suggest any SCC. On 17th of July, patient's urine culture showed growth of Pseudomonas aeruginosa, which was sensitive to Piperacillin, Tazobactam, Saptaginum, Imipenem, and Meropenem. The remaining urine culture was sterile. Mount 2 test was negative. Fundus examination was within normal limit, and fungal markers were negative. So this patient, 57-year-old with macerated decompensated cirrhosis in form of grade 1 ascites with severe hepatopulmonary syndrome, presented to us with history of fever for 2 months. Initial patient was worked up as a case of pyrexia of unknown origin. The urine culture showed growth of Pseudomonas aeruginosa, which was sensitive to Meropenem, Piperacillin, Tazobactam, and amikacin. Patient was started on injection Piperacillin and Tazobactam. Initial blood cultures were sterile, but the patient continued to have high-grade fever. A 2D echo was done, which ruled out any vegetation, clot. Patient had grade 2 gastric dysfunction. Bowel contrast was consistent with hepatopulmonary syndrome. Now I would like to call my radiology resident.
Good morning, everyone. So the patient underwent an 18 FFDG PET-CT on the 21st of June. So this is the maximum intensity projection image apart. Sorry. Apart from the physiological distribution of the tracer, you can see a focus of tracer uptake in the pelvis. In the corresponding transaxial images, we could find gliotic changes in the left high frontal parietal lobe, which are post-infarct. A coil was noted in the circle of Willis. Since this was a known case of CA tongue, we tried to look for any signs of recurrence. Part of the left tongue was not visualized with surgical clips and C2, with no signs of recurrence. On the pelvic images, we could find a focus of increased tracer uptake in the right peripheral zone of the prostate with an SUV max of 12.6 and another uptake in the right seminal vesicle with an SUV of 5.0. So, since the patient had fever and the uptake, the seminal vesicle uptake and the prostate uptake were non-contiguous, we gave a likely impression of an infective etiology. Apart from that, liver was also not, had an irregular outline with few perigastric perisplenic collaterals. So that's it. Thank you.
Patient continued to have high grade fever with and a variation of more than 1 degree Celsius. The temperature rose up to the maximum of 39.5 degrees Celsius, and at only one occasion it had touched the baseline. Repeat history taking an examination, physical examination was done to look for any potential diagnostic clue. There was a history of raw unpasteurized goat milk consumption for past 6 months. The last intake was 1.5 months ago. Atypical infection was suspected. The extended blood culture showed the growth of Brucella species on 22nd of July. The patient was initially started on injection amikacin and injection doxycycline along with injection piperacillin and tazobactam in view of coagulopathy. So after some time, coagulopathy has resolved and patient injection amikacin had changed to injection streptomycin, and patient had become afebrile by day 5. After discharge, patient did not have any fever spike at home. Patient had got a PET-CT done from outside, which has not shown any abnormal uptake in the prostate. So the final diagnosis of brucellosis, blood culture showing growth of brucellosis species. Possibility of genitourinary brucellosis could not be ruled out. With urinary tract infection, urine culture showing growth of Pseudomonas aeruginosa. Metabolic dysfunction associated steatotic liver disease related decompensated cirrhosis. The risk factor being hypertension and obesity, with grade 1 ascites and severe hepatopulmonary syndrome. Non-breeder, no history of HE. CA tongue status post resection, old hemorrhagic CVA aneurysmal bleed, status post clipping. So the points of discussion are immune dysregulation in cirrhosis and brucellosis. The 3 common mechanisms of immune dysregulation in cirrhosis are functional modulation of the innate and adapted immune cells due to the prolonged inflammation which is seen in patient of cirrhosis, intestinal dysbiosis, and the failure of intestinal and peritoneal barriers. The common infection in patients with cirrhosis are spontaneous bacterial peritonitis followed by urinary tract infection, pneumonia, and soft tissue infections. So coming to brucellosis, the points of discussion will be introduction to brucellosis, transmission, epidemiology, population at risk, clinical manifestation, lab diagnosis, treatment regimen, and the few case reports of patients of brucella in cirrhotic patients. So brucellosis, brucella is a small gram-negative bacteria, non-motile, non-spore forming, non-capsulated, aerobic, pleomorphic, with mostly occur in coccobacilli form, but can also occur in rod forms. It's a facultative intercellular organism causing a zoonotic disease, transmitted to human directly and indirectly through the contact with domestic ruminants and swine. So here's a picture showing the colony of gram staining of the colony of Brucella species. The Brucella melitans is the most common etiological agent, causes a more aggressive form of infection with the reservoir being sheep, goats, and camel. Brucella suis causes a focal infection in form of abscess formations. Brucella abortus causes a more insidious form of infection with a higher chronicity. The canis causes less severe form of infection. The main route of transmission is through the consumption of the infective unpasteurized milk product. It can also spread through the contact with the skin and mucous membrane or the body fluids of infected animal, or through the inhalation of the infected aerosolized particles. So Brucella melitensis and suis have been developed as a biological weapon by US in 1954. Population at risk are farmers, shepherds, veterinarian, employees working in a slaughterhouse and meat processing plants, and laboratory workers who are handling the infected samples. Epidemiology, the brucellosis is endemic in countries such as Mongolia, Kazakhstan, Iran. In India, considered as a possibly endemic country, but the exact data is not being available. So the common presentation of patients with brucellosis are as an acute febrile illness resembling typhoid disease, or febrile illness with monoarthritis, which is more common in children as compared to adults. In children, the hip and knee joints are the more commonly involved, while in the adults, lower back and the hip joints are the commonly involved joints, and can also present as a long-standing undulating fever, which is more common in older patients. So the common symptoms of the brucellosis mostly are non-specific. The commonest being malaise, fever, and arthralgia, followed by myalgia, sweats, backache, chills, and headache. So classically, we see a remittent pattern of fever in patients with brucellosis with daily temperature fluctuation exceeding more than 2 degrees Celsius. This type of fever pattern is also seen in patients with infective endocarditis, rickettsia. The musculoskeletal system are the predominant complaints in patients with brucellosis. In the musculoskeletal manifestation, musculoskeletal pains, osteoarticular involvement is seen in 10 to 85% of the patients. The most commonly involved joints are the sacroiliac joint and the spinal joints. The spinal brucellosis can be divided into 2 types: spondylitis and spondylodiscitis. Spondylitis can be of two types, focal or diffuse. Other close differential of the spinal brucellosis is the pot spine. In case of patient with TB, the deformity, paravertebral abscess, and psoas abscess are more common with canal compression, which is not frequently seen in patient with brucellosis. The discitis is the early involvement in tuberculosis patient, while it is a late involvement in patient with brucellosis. The less known osteoarticular manifestations are peripheral osteoarthritis, osteomyelitis, discitis, bursitis, and tenosynovitis. Genitourinary brucellosis contribute to the total 10% of all cases of brucellosis. In a multi-centric study done consisting of 390 patients with 352 male, it was found that the epidermolysis was the most common clinical manifestation, followed by orchitis, epididymitis, and prostatitis. In the females, pyelonephritis was the most common, followed by glomerulonephritis. There were few case reports of prostatitis abscess has also been reported due to brucellosis. Pulmonary manifestation is rare. It has an excellent prognosis. The common symptoms were fever, cough, pleuritic chest pain, expectoration, dyspnea, and hemoptysis. The common radiological finding in patients with pulmonary brucellosis are pneumonia, followed by interstitial pattern and pulmonary nodules. In neurobrucellosis, the rare manifestations, it contributes to 0.5% of the all community-acquired CNS infection. 3 to 5% of patients with brucellosis will have some form of neurological manifestations. The CNS involvement in brucellosis can be categorized into the three main categories, such as acute meningitis or meningoencephalitis, chronic peripheral form in form of radiculopathy, or chronic CNS forms in form of meningoencephalitis, myelitis, cerebral involvement, cranial palsies, and deficits. The gastrohepatic involvement, liver has been involvement in seen in up to 30 to 60% of cases with brucellosis. The asymptomatic hepatosplenomegaly is reported in 10 to 50% patients with brucellosis. The common lab abnormalities were transaminitis and the raised bilirubin level. There were few case reports of the cholestasis and visceral abscess, although they were uncommon. The brucellosis sometimes can also present as a gastroenteritis, colitis, and pancreatitis. The diagnosis of brucellosis is based on the history of potential exposure to the infected animals, clinical manifestation consisting with disease, on the supportive lab findings. The available diagnostic tests are categorized into the three categories: culture, serological test, molecular test. The definite diagnosis can be made with the culture, with the isolation of the organism on a culture, or by demonstrating a fourfold or a greater rise in the antibody titer. A preemptive diagnosis can be made with a single antibody titer of more than 1:160 on standard agglutination test, or by the detection of the brucella DNA by PCR. In the culture method, the bacterial isolation is possible in up to 50 to 70% of patients with brucellosis. With the newer upcoming automated blood culture, the isolation can be done within the 7 days. In our case, the bacteria saw the growth of the organism by day 5. The organism was further cultured over a solid medium, which on gram staining showed gram-negative coccobacilli. The further bacterial identification was done using Malditov, which is known as matrix-assisted laser desorption ionization time of flight. The drawbacks of Malditops are the misidentification of Brucella as Agrobacterium, Oncorobacter, or Psychobacter. In the serological test, mainly detect the presence of antibody against the LPS. The IgM antibodies were first to appear, followed by IgG1 in second week, followed by IgG2 and IgA antibodies. The production of these antibodies raises to maximum within the 4 weeks. The common serological test and their uses are undiluted rose Bengal test is used for initial screening. It has sensitivity of more than 99%. Standard agglutination test used for the confirmation of diagnosis. 2-mercaptan ethanol test used for the follow-up and the early detection and the detection of early treatment failure. The serological test, the standard agglutination test mainly detects the IgM antibody. It cannot detect the antibodies against the Brucella canis. So a titer of more than 1:160 considered a diagnostic in non-endemic countries, while a titer of more than 1:320 is considered a diagnostic in endemic countries such as ours. In 2-mercaptan ethanol test, IgM antibodies were neutralized and it detects only IgG antibody. That's why it can be used for the follow-up and the early detection of treatment failure. A titer of more than 1:80 is considered as significant for the treatment failure. The drawbacks of serological tests is the false positive test can occur because of the cross-reaction with species with organisms such as Yersinia, E. coli, Vibrio, and some serovar of Salmonella. A false negative test can also occur due to protein phenomena due to the presence of these non-agglutination antibodies. In the molecular test, we can use real-time PCR or multiplex PCR for the diagnosis, which has sensitivity of 100% with specificity of 98.3%. The drawback is it does not always imply the active infection. The laboratory manipulation of the brucellosis should always be done in class 2 biological safety chamber. The lab-acquired infections contribute to about 2% of the total cases of brucellosis. The treatments, coming to the treatment, the gold standard treatment is doxycycline 100 mg BD for 6 months. for 4 weeks with injection of streptomycin 15 mg per kg for 2 to 3 weeks with a relapse rate of 5 to 10%. Coming to alternative regimen, rifampicin and doxycycline can be given for 6 weeks. The pros of using it is that an oral regimen, it is easy to administer. The cons is relapse rate of more than 10%, and the simultaneous administration of doxycycline with rifampicin, as the rifampicin is an enzyme inducer, it reduces the level of doxycycline, and it can lead to the development of the rifampicin resistance, especially while treating patients with tuberculosis. Other regimen include gentamicin, in which it's given for only 1 week with doxycycline 100 mg BD for 45 days. This regimen has a similar relapse rate with doxycycline and streptomycin. By reducing the duration of doxycycline treatment to 30 days, it has been seen that the relapse rate has increasing up to 23%. But this trial required further clinical trial for the validation. For fluoroquinolone, it should not be used. It should not be used as a monotherapy. It should always be used in the combination with doxycycline or rifampicin. In one clinical trial, it has been found that the monotherapy with ciprofloxacin alone has a treatment failure rate of up to 33%, while ciprofloxacin with doxycycline has a treatment failure of 0%, but in this, the duration is more than 3 months. Trimethoprim sulfamethoxam can also use for the management, but it should also be used in combination with either doxycycline or rifampicin. With doxycycline, it has a treatment failure rate of 7.1%. With rifampicin, it has 16.4%. As it is orally available, it is cost effective and can also be used safely in pregnant females. The other tetracycline that can be used in management of brucellosis are minocycline, oxytetracycline, and tigecycline. For focal brucellosis such as neurobrucellosis, triple regimen consisting of doxycycline, rifampicin, and cephalosporin is required, and it is considered as a standard and first choice. The minimum duration of therapy is 6 weeks. In some cases, it can be extended up to 3 to 6 months. Endocarditis accounts for 1% of all cases of brucellosis. The aortic valve involvement is more common as compared to the mitral valve involvement, and when the aortic valve involvement is there, then there are a higher rate of left ventricular failure and greater mortality is associated. A triple regimen is recommended for the management with the doxycycline, rifampicin, and aminoglycoside. The duration of doxycycline, rifampicin should be given for 12 weeks, with aminoglycoside should be given for 4 weeks. There are some few case report of patient with brucellosis and cirrhosis. In case 1, this patient was a known case of decompensated cirrhosis, had presented to a hospital with a history of fever and abdominal distension for 6 months, and there was a history of unpasteurized dairy product consumption. So the patient had pancytopenia with elevated CRP. The blood culture showed the growth of Brucella species. The patient was initially started on trimethoprim sulfamethoxazole and ciprofloxacin combination, but patient did not respond, and patient continued to have worsening of the pancytopenia and strange RFT. The later on patient was shifted to doxycycline and ciprofloxacin. The fever was subsided and pancytopenia RFT on improving trend, and the patient was discharged. But again presented with history of hepatic encephalopathy, and it was attributed to the antibiotic associated toxicity, and the patient was further referred for the liver transplant. Similarly, in the second case, it is the 50-year-old male known case of alveolar cirrhosis who was suffered by occupation, presented with history of fever, mild back pain, diarrhea, and abdominal distension. On evaluation, patient was having elevated CRP with raised total bilirubin, direct bilirubin, with multiple intra-abdominal lymph nodes with necrosis. The blood culture showed growth of brucella. The patient was initially started on a regimen consisting of doxycycline, rifampicin, and ciprofloxacin, but the patient fever subsided by day 5, but patient had continued to have elevated bilirubin, which was attributed to rifampicin, and the dose of rifampicin was reduced to half, and patient was discharged. But the patient again readmitted with HE and raised bilirubin, and again it was suspected due to the antibiotic toxicity, and the antibiotic was discontinued, and patient referred for the transplantation center. The take-home points being brucellosis is an uncommon zoonotic infection in the cirrhotic patients. The diagnosis is challenging, and the blood culture is this gold standard in the diagnosis. High index of suspicion is required for the diagnosis.